that, or here, I got it. I should be able to get it. Patience, flag. Hold on, no, I'm gonna share my screen. We're gonna just, I'm working on sharing the screen. And we can call the meeting to order. There it is. All right. Call this meeting to order. We'll start with the pledge.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. All right. There we go. So first, I would like to welcome Dr. Vento. Thank you. She was attending her first meeting. And I don't know if Jonathan can pan the camera over that way so everybody can see. So he's got this nifty remote, so you can wave to everybody out there. And then I'd also like to introduce and welcome Jessica Thompson, who is new to our office. So welcome to both of you. And I think we'll do a quick roundtable introduction before we do the minutes, as we've welcomed the new people. So we'll start out there in virtual land. Amanda, would you like to introduce yourself and let Jess and Dr. Well, you met Jess the other day, but Dr. Vento know a little bit about you?
Hi, my name's Amanda Henry. I'm the Chief of Operations for Carthage Rescue. I've been in EMS since 2002. I do have my bachelor's in EMS management. That's about it.
So, Melissa, I'm just kind of following across the screen.
Melissa Brooke, paramedic, deputy director at Governor Rescue.
Dr. Gray.
Welcome. My name is Maya Gray. I'm a practicing emergency medicine physician at Samaritan Medical Center and been on REMAC since '98, medical director to a number of ground squads and also to LifeNet of New York, Watertown, Seneca Falls, and Potsdam bases.
Justin.
Hey guys, my name is Justin. I'm a per diem paramedic over at Ogdensburg Rescue.
And Dr. Maynard.
Hi, it's Matt Maynard. I am the nocturnist in the ER at Samaritan. These meetings are always at 4:30 in the morning for me, so no, Ann, I will not be turning on my camera.
All right, we still love you.
And Matt is our state
CMAC, right?
CMAC representative as well.
Colleen, I see you out there.
Hi, Colleen Gleason. I am business development with LifeNet of New York for the Watertown and Potsdam bases.
And then we have Mr. Zecker. Is he paying attention?
You're really going to get me while I'm driving. I appreciate that. So,
Oh, I didn't realize you'd left already.
That's okay. My name's Tom. I work for Fort Drum Regional Planning, Director of Information Technology, just here for a support role.
Yeah, he's helping make sure our hybrid meeting goes well. So thank you, Tom. So I think that's everybody online. You want to start over there, Jonathan?
Sure, as soon as I figure out which way to push the camera.
Oh, sorry.
So I'm Jonathan, you're both on camera. I don't know why you can worry about the camera. Jonathan Cole, I'm the EMS Programs Assistant for Fort Drum Regional Health Planning. I'm also a Deputy Coordinator for Jefferson County, and I cover Zone 4, which covers a large chunk of Fort Drum.
Just real quick, a little bit about yourself, even though I introduced you.
So Jessica Thompson, I am back to North Country and here to stay.
So I am back up in the Canton, West Potsdam area, running with Canton Rescue and also with Potsdam Rescue and the new EMS People Coordinator.
I'm Bob Bowman. I'm from Beaver Falls Ambulance and also volunteer with Lewis County Search and Rescue.
No, Bob.
I'm County Director of Fire and Emergency Management for Lewis County, also EMS Coordinator and volunteer paramedic at Lions Falls Fire Department, as well as their fire chief. I've been in for a few years.
Welcome, I'm Sarah Delaney. I'm a practicing ED physician at Samaritan.
And the chair of the council,
I'm the chair.
of the committee. Debbie Singleton, I am the chair of the REMSCO.
Ann Smith, I'm the North Country EMS Program Agency Director for FDR HPO.
Technically, no.
I'm Mark. I'm the vice chair of the REMSCO and SEMSCO rep.
So I'm Colonel Bento. I am the Deputy Commander for Clinical Services, or the CMO equivalent outside of the military up at Fort Drum. Trained in family medicine and behavioral health. So psychiatry mainly is what the Army used me in, and then I went back for a fellowship in child and adolescent psychiatry. So nothing to do with emergency medicines. But I am your chief doc up at Fort Drum.
Chris Singleton, I'm the training education coordinator for Jefferson County EMS and volunteer paramedic with Salt Jeff Rescue down in.
Brian Coates, of the EMS medical director for San Luis Health System.
Okay. So thank you, everybody. And again, welcome. We have not had a meeting in quite some time, since April. So the minutes were sent out for review, and I would entertain a motion to approve those. Motion by Dr. Coates. Is there any,
Second.
a second by Dr. Gray? Is there any additions, deletions, or clarifications on the minutes? Okay, so if anybody, wow, we gotta, I know how we do it when we're fully virtual, and I know how we do it when we're fully present, so let's see, anybody online opposed to accepting the minutes, speak now. All in favor of accepting the minutes in the room, please raise your hand. Okay, unanimous. Thank you. I didn't give the voting much thought. All right. So next I will share the DOH enforcements, and Debbie, if you want to go over them.
I think we can let people just take a kind of a look at them here.
Oh, wait a
state-
minute. I don't think I'm sharing, sorry.
That's right. The state has been very busy. It seems like there was none in August, but July and September, they've been hitting it pretty heavy again. So one thing that we do need to look at from a council is we probably need to look at what some of these violations are and look at the big ones and see what the issue is and make sure we're sharing with our providers. You know, if you look at 800.16 and 15 seem to be, there's 15A2 seems to be a lot of them. So we probably need just to take a look at some of these and make sure that everybody's aware. I know Ann had sent out a thing there that showed some of the things when folks are audited, when the state comes in and does inspections, these are the main things they're finding. So I think we need to take a look at these and say, Jesus, there's something we need to look at, make sure people are in compliance. But unfortunately, there's a lot of people that have been suspended. And the fines are anywhere from $500 up to $2,000 that people have been hit.
Do you notice all those people there are like the first digit? These are new providers, 46, 45. These are all new providers. I'm wondering if there's something in the education that they're not getting, or they're new to the agency, they're not getting. These are not seasoned people.
Look at
Except
that
for the
one.
last one.
Okay, one is. You didn't scroll down. I mean, look, they're all new providers, relatively new providers.
So I think that's something
Something-
probably we need to look at. So we'll see if we can't get some folks to review and see what it is.
Oh, I lost you. There you are. Okay. You guys were all able to see that okay out there, right?
Yep.
Thumbs up.
All right, so correspondence. We received notification of multiple stroke center designations. Saratoga Hospital is the closest to us. And they are a primary stroke center. Then we received notification, and I'm not gonna go through them all. If you have any questions, well, I guess I should, because you may transfer, the physicians may transfer to them. So we had 2 comprehensive stroke centers, which is New York Presbyterian Hospital and the Wheel Medical Center and Columbia University Irving Medical Center. Thrombectomy capable stroke centers are at Mount Sinai, Beth Israel, Lincoln Medical and Mental Health Center, New York City Health and Hospital, Elmhurst, and New York Presbyterian Brooklyn Methodist Hospital and St. Francis Hospital. So those were all stroke center notifications. We also received a correspondence from the Bureau of EMS that their surge operations centers will no longer be sending email notifications for hospital diversions. Real-time hospital emergency department statuses can be viewed on the New York Diverts webpage link. And if you need more information regarding that, contact us and we'll be happy to walk you through that. It is the Jabari system. And one of the challenges that we've had is our Jefferson County hospitals have been spectacular about using our EM resource, which is good. And it's really the same thing that the state has. But they don't have all the hospitals or EMS agencies in where we do. So those are the correspondence. Anybody else have any other correspondence? And I have one more.
Yes.
We did receive a resignation letter from Dr. Snicer as he was moving out of the area. So under new business, we will move to vote on that. So any other correspondence? Air medical report. So Colleen, do you want me to pull up the stats or do you want us to just share them?
Please feel free in sharing them.
Okay, do you want to report on them now or do you want me to just?
I can forward you the, so you can show them. How's that? Bear with me.
Oh, no, I have them here.
Okay.
I have them. I just didn't know if you wanted me to pull them up or not.
I'm driving, so if you could pull them up, that would be great.
That's the committee. That's not the right one. I must not have opened it already. Okay, Jonathan's sharing it.
Thank you.
I want mine go away. I don't know why this window won't go away. All right, so they're up, Colleen.
Thank you very much. And I'm sorry, I'm actually headed up to you guys. Just got a late start, so I'll be there definitely at 1900. So what I did was I did totals for Q3 for 2022. And then of course, in comparison for totals for 2021. Last year was a very busy year, and more or less this year, what we're seeing is we're very busy, but we are out, we're declining due to not just weather, but also for patients, the acuity. We've been seeing a huge change when it comes to acuity, whether we're flying really sick patients and or we're flying those that need testing. We're flying long distances, as we all know. We're also going by, not us, but ground EMS agencies are doing longer distance transports for interfacilities. So weather has wreaked havoc on us, but the numbers are fairly consistent when it comes to the 3 counties with Jefferson, Lewis, and St. Lawrence County. And these are scene calls specifically. And I obtained all this information. This is clearinghouse report that we collect each quarter. Does anybody have any questions?
This is Matt Maynard. I have a question. That you said you're declining patients because they're too sick. Give me an example of a patient's too sick for you guys to fly.
I may have misspoke, but not too sick. I meant to say we're declining because they're probably not sick enough and or due to certain testing that needs to be done.
Gotcha. Okay.
Sorry.
Sorry. Any other questions for our medical? All right. Moving on, we'll go to state EMS meetings for September 21st and 22nd. The next meetings will be December 6th and 7th. Mark, do you have a report from the state EMS meetings?
So there's actually been 2 state EMS meetings since we met last. The first one
Absolutely.
was in July. There was not a quorum for CMAC, so that one was pretty quick. For the meeting a couple of weeks ago, the highlights of the conversation is they're still working out some regulatory boundaries and burdens for the physician fly car program that a lot of hospitals are doing. Essentially, the hospitals, Samaritan, for example, to buy a fly car. What hospitals are doing is they're buying a fly car and putting letters on it and operating it, and it's not the most legal game. There's questions even how the narcotics are stored and controlled. And nobody's really given them operating authority. And of course, as with anything, when you get the Department of Health involved, it always becomes entertaining. They're doing an awful lot with quality metrics. One of the things that's definitely been identified is we're getting a lot of data, but the data is inaccurate. So they're trying to cut out some of the data points and streamline some of the data points. And the providers in the room will tell you, if you select a stroke, you have 18 different options for where in the brain this patient's stroke is. So the data basically stinks. And then they did a whole bunch of New York City protocols and made a few changes to the statewide collaborative.
Those on the agenda go over here.
So they changed excited delirium and pediatric mental health, and basically did a lot of words. I think it's excited delirium is not everybody's favorite word. They approved TXA and Afrin. Effective 1/1. The AEMT will no longer be able to intubate. And they're looking at a few things with trauma centers with the new trauma triage guidelines that ACS put out. They want some little bit of guidance on what patients should go to a level 3 trauma center versus a level 2 trauma center, et cetera. Up here, it's not really a big issue where we are 90 miles, well, 140 miles in between trauma centers, and hopefully we're going to have a 90-mile gap between trauma centers here in the future. So it's kind of go to the closest trauma center if that's even an option. However, they are seeing a massive uptick in level 3 trauma center applications, so they would like some guidance because there are places where patients are appropriate for level 3 trauma center, and they're taken to level 1 trauma center. Vice versa. And they did clarify that if there's not an ambulance transfusion service available, a non-ambulance transfusion service agency can transport blood in their facilities. And finally, they looked at clarifying the regulations to helicopters doing blood. There's a law that allows it, but apparently there's no real regulations. So I'm sure New York State will make that a fairly easy and streamlined process as well.
So my question on the blood ATS service that there's none available, they just said any ambulances. Is there any clarification? Because I can see that question coming. What does any ambulance mean? Critical care, paramedic, or does staff from the hospital have to go?
I will get you that answer. And so blood, because of the way it's regulated, is kind of a goofy monster of its own. And where the issue is the hospital's laboratory license is good for the 4 walls of their facility and not the 4 walls of the ambulance. So I don't know how that, it really has nothing to do with credentialing other than appropriate a CC or a paramedic would be my advice. But it has nothing to do with who's giving the blood. There's no laboratory license for the ambulance.
That would be huge to clarify though. This comes up all the time. Like if we can start blood products and they're running and the ambulance can continue them, that would be amazing.
So
I think you've got the only transfusion.
There are places that do that.
Yeah.
But it's a need, and there's a massive gap up here for it. Unfortunately, the process is incredibly burdensome. And I would also just offer that your employer may have some options to improve that moving forward.
So based on that, AEMT no longer being able to intubate, we need to update our CMEs. And I did look at the ones for this semester, and intubation isn't one of the skills because there was a lot of discussion on that. And if they are testing out in December, they're not going to make them test out at that.
So keep in mind, these protocols, while approved at the CMAC and SEMSCO level, they will not go into effect till sometime next year.
Yeah.
Well, with the AEMT removal of intubation being good on the 1st. So we have some education and all of that stuff to complete as of yet.
There's something going out to the agencies to notify them of this change so that they let their providers know.
There will be once they're approved, but I really hesitate doing anything till we get the blessing because things tend to change 16 times.
Do you think it could change about the AEMTs innovating? You're
The
saying
date that it's happening. I don't, you know what I'm saying?
Or instead of 1/1, it might be another date.
Well, so the approval process is quick.
We will hopefully know in December.
But when stuff goes to the commissioner, sometimes things are approved in 6 months and sometimes they're approved in 18.
We're gonna be tracking to get everything ready to go out, but based on experience, I'm not sending it. If
Not yet.
the Bremsco wants to, REMAC wants to send it again, I'm not doing it.
So the last protocol updates that they did,
Oh, what a nightmare.
We didn't even know.
we didn't even know that they were
Yeah.
approved and found the training randomly online that was from 6 or 7 months prior to when we found it that the collaborative put together. So the communication coming out of Albany sometimes leaves something to be desired.
So basically, one of the decisions discussed as well is the protocol changes. Because there was a lot of concern voiced over providers being confused, and rightly so. That one time a year, that's it for protocol updates. So everything can percolate and be ready to go out one time a year. So I'm gonna guess January might be there one time a year, and there may be more changes that come forth in December. So I'm sorry, I just hate to jump.
You want to talk about the BLS people doing secondary ones?
The other semi good news, and I will echo what Ann just said, that we don't really know what the time frame is on this because stuff moves slow. There's a pilot program for supraglottic airways with basic providers only in cardiac arrest. And it's specific to the iGel. It's being ran out of the Hudson Valley area. I don't know exactly which region is managing it. And they've agreed to open it up statewide to regions and agencies that wish to participate.
And we're still waiting on information to be able to get everybody
So
going on that if they're interested.
and for those who are kind of unfamiliar with an iGel, it is an incredibly simple device to use. So, are there any other questions?
So we basically already talked about any other questions for Mark or about state EMS meetings? The minutes from the last 3 or 4 will make sure that they are attached with the minutes when they go out.
How about my pilot?
And Debbie put in a pilot to do essentially an EMT to a EMT class all in one class. The last I heard, the pilot was not completely approved, but they thought they might have a workaround. Again, the state has some goofy regs. By the sounds of it, it's run a full basic EMT, and then there's a way to do an abbreviated AEMT, was what I kind of understood.
Ryan wanted me to give him just this week to do some stuff. We'll follow up with him on Monday because it's supposed to start November 3rd. So and they're saying that what we'll do is they won't retest the skills that they did at the EMT when they just finished that up, that we're going to be able to just do the new advanced skills.
But they'll have to pass the basic practical,
And
sit
written.
for the basic written, and then essentially come back that next Monday and start in with the ability to do their AEMT stuff. But most of the education would be kind of preloaded. They're gonna be taught at the AEMT level at the beginning so that there's less toward the end.
So in all state classes, there's a lot of redundancy in the education. The first month of paramedic school, AEMT school and EMT school are basically the same same group of classes. So a lot of this idea is getting rid of teaching med legal 4 times to the students. And also part of it is kind of consolidating and only teaching chest pain once instead of teaching chest pain at the EMT level and then the AEMT level, which half the class are the same. So hopefully that will get approved. And
So we would be taking the basic EMT is 6 months,
5.
5 months, the advanced is 6 months. So that's 11, and we would be taking it down to 8 months. So the hope is that we could get some advanced providers out there. And, get some of that out in the field, so.
Any other questions regarding state or any other comments? Hearing none, moving on to old business. So protocols were first on the list, so Mark already went through most of them. So, you know, stay tuned. You'll be seeing, some changes come the beginning of the year or so. So the old protocol changes that got changed without our knowledge, we did, when we found out, we did send correspondence out to the agencies. That was the addition of TXA and Afrin for nosebleeds for the epistaxis protocol. We have a training video out there and a short little exam for those agencies who are using Afrin. The TXA video, we've done it like 2 or 3 times. It's in the editing process and the exam's written. I just have to double check the questions and make sure they all are still relevant now that the video was redone. So once that's done, that will be out there. So the general education that was done by the collaborative referred to specific education for those 2 medications, of which were nowhere to be found. So I did those with Dr. Bombard, who's on the collaborative group as well. And hopefully we'll have the TXA one out here soon. And we did in the North Country, we did purchase bracelets. So again, if your agency is going to use TXA, then you're supposed to notify the REMAC of that or our office, and we will send you bracelets so you can put them on a patient. If you do start to administer it in the field. So. Anything else on the protocols? One of the things with that he talked about with the additions, there will be a resource for de-escalation techniques in the protocols, and the excited delirium protocol will no longer exist. That has been incorporated into the behavioral protocols moving forward, and a new adolescent behavioral agitated patient will be included in that as well. So those changes will probably be flipping out the beginning of the year, and we'll see what December brings, if there's anything else to add to that. Any questions on the protocols? Anything else? I did get Dr. Maynard added to the collaborative protocol group as well. So the quality corner, do you want to talk about that, Melissa, at all? Throw her under the bus here.
Okay. So we had taken the summer off. I hope we can get that going again for the quality corner. Am I explaining it for our new people or?
No, just what we've done, because we haven't met since we put out, I don't think we've met since we put out the trauma one.
No, I apologize for that. My spring was a little rougher than I anticipated, so I'm still in catch-up mode from that. We've done a couple of newsletters. One of them was on trauma and our scene time, and we found out in this region we are doing relatively decently. We had very few patients on scene for over a half hour. We have also done Versed and making sure we're using Versed appropriately. We did find some issues in our chart review that we were able to push out some education to the region, such as keeping our trauma patients warm, documenting how much fluids are being administered, and then on our Versed airway assessments and ensuring that the SpO2 is documented as well as oxygen as needed. Anything else, Ann?
No, I think that's a moving forward. Jess will be joining the team and will be kind of heading up that project from our office side with you guys.
Wonderful. So, I'm also looking for any ideas of anything anybody would like to see us review.
So the data committee, I think Mark summed it up pretty well in what he said. We've had multiple meetings, and but we've kind of taken the summer up and leading up until summertime. And we're going through section by section, and what we're finding out is even with seasoned providers that are very, very familiar with electronic documentation and the platform that they utilize. So we have a representative from each EPCR vendor platform within our region, that we all perceive what should be in that field differently. And we still do not have a data dictionary from the state. And we've had some meetings with the data and data informatics team, really pushing that they need to do this education stuff. There's a lot of controversy over helicopter landing zones and how they're documented since they removed our generic landing zone that you could put in there. Some of the systems may have a free type in there, so we get some very interesting landing zones. So we've dealt with that with many agencies, so we'll keep moving forward on that. Anything else on the data committee?
Can you allude that there's gonna be some more nemesis changes?
I have that in mind.
Okay.
I have that in my program agency report. Allude nothing.
No, they're coming. New version.
Any, anything else under old business? Any other old business? Jonathan, do you want to share the program agency report? All right, move on to the program agency report. So we'll start off with the RTAC while he's pulling that up, and then he can skip a couple slides probably. You guys see that okay out there? They're all frozen. Okay, I got a thumbs up. All right, so RTAC. The meeting was Friday, September 3rd, their 30th. Oh my God, I forgot the zero. That should be 30th in there. Because of the ending of the executive order, there was no longer a virtual option, and they moved the time up to 11, hence not very timely on my part. So I'm hoping that some of our other folks have a better follow up on that meeting that are at the REMSCO. The next meeting is to be determined. I don't know if they decided on it, but they do have a new chair. And now, since the passing of Dr. Marks, which we reported last time, it's been quite a while since there's been an RTAC meeting due to all that. And then Jolene Kittle's been the RN trauma program manager, is taking a new position. So I'm not sure if I believe she kind of was the secretary to the program. I don't know who's going to be in that position at Upstate. And they did elect a secretary from another trauma center in the area, in the region. So our stack, we've had multiple meetings. They remain virtual. I'm going to have the minutes shared electronically. I will say that there's some AHA initiatives out there for EMS in rural hospitals. They are pushing, I should say not pushing, encouraging critical access hospitals to consider enrolling and get with the guidelines, and they'll cover some of the fees for that for the first few years. In EMS, if they're going to be collecting data specific to stroke and STEMI, they can be potentially awarded, and there's 3 tiers based on data measures. And I think that's shared on the next slide, Jonathan. And these will go out in the minutes, and that's why I threw them in there. But so specifically to EMS, the award levels of bronze, silver, and gold, and then the criteria that they're looking for. So the AHA representative was on the RSTAC meeting talking about this. So this will be in the minutes for anybody who wants to study it further. We'll keep on rolling. This I reported at the last meeting. We rolled it out in Spring Fling as we had discussed. We continue to promote it. We still have some funding available. Next. Whole list since the last meeting of all the agencies that have done their renewals, and I had a group of them blue because something changed there. There is a group of BLSFRs that did their photo registration upload to stay in the CME program before the deadline, and then they did not copy us, nor did we get their BLS approvals back when the state requested additional paperwork. So I really don't know the status, and I think it's to vary it down. So they submitted through the portal like they were supposed to. The state requested more, and I don't know whether they've sent the more in, and the state hasn't sent back the BLS stickers or update, or if they're still waiting for information. So those will need to be followed up on. Next. Medical director changes. So do we want to vote on these? Right here, we only have to do the physicians, so.
Make any comments about ours as well? Information coming as we just found out that Major Griffin Bijan is deploying.
We just need to put that as person currently in the position.
So he's the other orthopedic surgeon or. Literally, as soon as we submit it. Yes.
Been an evolving door.
Well,
Actually, that's how it.
That's how it is.
Yeah.
So one of the discussions that I had at one point, and maybe you can help kind of facilitate this. Is there a way that we can put maybe a civilian medical director in that works jointly with whoever's there, so the eight?
Love to. The problem is we don't really have civilian providers that either have New York State licenses or are, that meet some of, that are probably appropriate for the position. So we may have like a pediatrician or something that may not be appropriate. Because they don't necessarily need to have a New York State license to work for us, right? So that's factors. Or they don't belong to us at the hospital. They may belong to the division, which then we have difficulty tasking them to go to meetings. So I don't own them, and they too are also deployed frequently, right? So probably more so than our providers. So we are very limited when it comes to frequently finding somebody that meets all the criteria. We did look for, that definitely was somebody we were looking for when we were trying to find someone for the position, but we thought because Major Bijan had more time here at Fort Drum, he would be the better choice. But they also, I think, knew then that.
Okay, well. So what's happened since we haven't moved or haven't met in a while? And some of them, you know, they needed for renewals. We did provisional approvals. I had spoken with Sarah about those, and they all have received provisional approval. So I would venture to say that we move forward with voting, and then we'll do the paperwork again.
Yes.
I would love to find, because you know, for the agency itself, it's just very difficult. It's a lot of paperwork. Even though it's all fairly templated, but.
Understand, I'm signing many of those papers too, so completely agree.
So.
Was not our choice.
I know, it's that we know,
Our surgeon
no.
particularly.
We know, we want to try and find a solution that makes it easier for the, you know, everybody involved.
Right.
But I would, so Dr. Quinn for Edwards Fire Department is emergency physician for St. Lawrence Health Systems. Dr. Coates, do you know, can you add more in?
Oh, Adam's really nice. What? He's the governor medical director right now,
Yes.
and he's trying to start to weigh into the stuff.
Chris.
Seems really low middle on his heart, so he just wants to try it out.
So, okay, no, that's what I meant. I mean, I figured you would know more about Dr. Quinn than I do.
That's nicer than me.
All right, so I would entertain a motion from the physicians to accept this.
I make a motion to accept all those physicians listed with a provisional acceptance to the next medical director for Fort Drum Ambulance.
Okay. Is there a second to that? Second by Dr. Coates. The motion was by Maya, Dr. Gray. And second by Dr. Coates. Any further discussion? So we can do, I can actually just do a roll with the physician. So Maya and Dr. Coates, Dr. Bento, would you approve that? Dr. Delaney and Matt. Dr. Maynard,
Yes.
did I get them all? Okay, unanimously approved. Okay. We will give them the officials. So moving on. So BLS adjuncts, the only one that we had is we received the application for Briar Hill for BLS blood glucometry. I'd entertain a motion for approval of that, pending they don't have their Wadsworth yet. They've applied. Or did we get it? So they've applied. We're waiting for the license, so. Told you had Belleville's.
Make a motion to approve.
Okay. Is there a second to that? So motion to approve by Dr. Gray, seconded by Dr. Coates. So that, all other physicians in favor? Yay. Matt?
Yes.
Okay. That we had Belleville's what, Debbie? That,
I'm
because
going
we
to,
made,
their blood glucometry. They told me they'd submitted theirs. Because they're doing blood glucometry. I'll make a call to
Okay.
on my list here.
yeah, I don't know why I just didn't take that off the old slide. We do? Is that a new one?
That's a new one.
Oh, that's a new one, sorry. I was thinking of Constableville and Black River. And so BLS 12 lead for Indian River, we have all their information for that. Need a motion, I'd entertain a motion for approval. Dr. Coates, this one's on you. I have a motion by Dr. Coates for approval,
I'll second that.
seconded by Dr. Delaney. Big Maya froze. All in favor? Matt?
Aye.
Maya, are you still there?
I am. I.
Okay. Approved. All right. So, as many of you may have seen, a new policy statement came out on September 7th, and I just copied its purpose up top there. I'm not going to go through all of it. But basically, so that EMS providers could get logged into the HCS system, the agency leaders could become HCS coordinators and sign their folks in. And that each provider could see their own print their own digital card. Great, great stuff, except the challenges are for me to put an agency leader to become a HCS coordinator, they have to get a notary signature on a form that we have to generate that has a specialized barcode that needs original signatures, and it would have to be mailed to all the agencies, which was not their intention. When you go to sign up and do your match it, or you go to sign up so you could get your card and you follow the instructions, a lot of times it will not work. So I beta tested it locally with Mark and Melissa, and neither one of them were able to see their card. I've been unable to update agencies in there. So we have some agencies that aren't even in there. So we met on Friday with Dan Clayton, and he brought in somebody from the health commerce system. We met with them again today and told them all of our challenges. And there's some plans that are happening to make this paperless, so all that notary signature stuff doesn't have to happen, because that's just going to be a nightmare. But they also have to elevate the program agency director's level of permissions in HCS to make all this stuff happen. So we're gonna have a follow-up meeting on this on Wednesday with the developers, because when they sent us the list of agencies, some of the agencies that I didn't have in there were in there, but they've coded them different, so we can't see them. So we don't know who's seeing them. Anyhow, we're working on all these challenges, so what I'm asking is please spread the word. We're not gonna be able to sign all the providers up on HCS. As an agency leader, I'm not gonna be able to make you an HCS coordinator until we get this figured out. We'll see if it works with Mark. He did do the notary form and send it in. But again, it just doesn't make sense for us to generate that for all the agencies. And apparently they're time specific. So if you don't send it right, get it notarized and send it right in, we have to start the process over again. So I have had some requests from our agencies. I'm just, again, Wednesday, I'll know more before I reply back to them, but that's the holdup. And if you can't view your card, if you're already a user in there and you go through the process, it may be because the DMV, Bureau of EMS's prod system, and HCS, if your name doesn't match perfectly, like if a space is different, you're not going to be able to do that. So we figured that that's probably why, because most people, when they set up in the HCS or on their license, you may not have your middle initial. And I would assume that prod has the middle initial because that's what's asked for on the DOH 65 form for students. So those three databases don't match. Yeah, it's not happening. So those are the challenges.
Still struggling to get people in there. I have somebody that tested in June. And of course, their last name is Johnson, and there's 98 pages of Johnson's. So I tried it with just her first initial and everything, and I called down there, and the last time they said, well, we don't show she tested. And I said, okay. Could you get a copy of her printout from it? And I said, yep, I have it right here. So I had to scan it and send it to them. And she called me, she said, I just got my card in the mail. So we're struggling with that as well. People that have tested, they have the form saying they passed, aren't
Right.
showing up in the system either.
But is she in the HCS system? Because there was a bunch of Mark's class that still weren't there.
That's why I haven't looked yet. She just told me yesterday she got her card in the mail, so.
So there is an email that, any testing, which we're sending those to testing issues at whatever it is. Yeah, but I know it's not, I don't quite remember the email. I have to look it up, but all I need is I ask providers when they bring that to my attention to provide me with a printout, or we email them into there. So there's a multitude of them. And it was around the June timeframe.
So it must have been people from that June test.
Yeah, and it doesn't matter. We're just aware of the ones mostly because they tested here and we'll register them in the system. And then the agency will go look for them in the system and call me and want to know if I registered somebody who didn't show me a card.
Well, it's just frustrating from the core sponsor end because they can't get reimbursed for these people that took the EMT class until they joined the health commerce system. So.
So anyhow, moving on, we got some, BLSFRs and an ALSFR that is going live with Image Trend. Boy, here we go. Here's your data integrity. So now they're talking about doing a schematron update on 123. They're looking at removing schools from the facility list. I don't know what some of the other stuff they talked about on the call. Irregardless, you'll see more information about that. They are also working, as Mark said, on paring down like the primary problem, because again, under ICD 10 codes, that is what they have in there. You can have, you know, if somebody has a stroke, they want to know the, you know, the location of with the vet, or, you know, the vessel that's affected. And we don't know that pre-hospitally. So one of the things that we're doing, we did have somebody bring us a concern about the amount of IV fluid administration for our major trauma patients. So we pulled the data on that, and surprisingly, it's a very low number for year to date that are documented as meeting any major trauma criteria and having normal saline administered. So we are working on, Jess is actually working on reviewing a lot of them, but I have to question that there's something wrong that would give us that few number of charts for, you know, quite a few months. So I don't know. We're looking at that. We should have a report on that. Jess, did you have anything to add while you're working on it?
It seems to be consistent though. I don't think that, I was gonna say, it seems to be consistent though. I don't think that there's too many outliers with the numbers that we see over the fluid, but they're only less than 30 over the course of, I think, 9 months it went out to.
Yeah,
Some
30
charts.
And that's Tri-County. That's just the North Country region, right? And Mountain Lakes didn't have many more because we pulled
from
both.
Mountain Lakes. The rest were trying. There was very, very few that seemed to be surprising.
Yeah, so we gotta look at that, whether it's something within the documentation or what's going on with that, speaking of data integrity. But the good news is we didn't find anybody flooding people. So that's very good. And we are in the process of determining whether they're documenting 1,000 or 1 liter as the bag that they hung, or as the amount of fluid that they gave. So that's what we're looking at.
Bet there's gonna be a lot of that. They'll get like 200 or 300, but they put up a liter. So it's just documented as liter.
Yep. So that's what we're looking at. And oh my God. ESO. So ESO is a software vendor. And we're having like over 1,000, what was it, Jonathan?
For the last 7 days, I had 1,000 upload failures from ESO.
So irregardless, the state is involved in this. We had uncovered some of these problems when there was a vendor change, an agency changed the vendor. And then we discovered it was much more than just that agency's problem, as their uploads weren't going through it. It's everybody who uses ESO.
And it's not just isolated to the North Country region. Central New York's got issues with them. It's across the state that they are failing schematron uploads. And it's something in their software that's allowing the charts to lock as complete, even though they're missing validation points.
So we're sending routine reports out. This takes up a lot of Jonathan's time. I mean, it's it's
Well,
crazy.
1,000 in that many days, that's a lot of charts.
You know, we try to notify the agency and finally I'm to the point where I told, because the way the reports pull, he has to singularly look to go back and find the incident number. And as of today, I'm like, there's too much other stuff to get done. So send the failed charts to the agencies. The agencies need to go into their software and figure out which of those charts failed. So. I keep wanting to click it, but he's control. So, the CME, again, we went through and did the list. We didn't send letters out. Instead, we worked with the agencies. There was quite a few people that were removed from the system, a few that came back online. At this time, since we sent emails again to the agency leadership, there's only 2 providers out there that have not done their June CMEs. Agencies are getting much better about letting us know that the provider is no longer running with them, so. Next. So up and coming training, surviving and thriving when words count, which is an EMS financial management seminar. It will be offered here on, you only need to attend 1 of 2 sessions. October 20th and 21st, the flyer just went out. We are doing in-house and hybrid or virtual, excuse me. So you can sign up for those. There's a little tiny fee for both of them. So they are very, Maggie Adams is doing this and she is a phenomenal presenter. Spring Fling, save the dates out there for April 27th through the 29th. The call for speakers has gone out. And the exciting news is we have signed the contract to purchase a learning management system, which will be each agency hopefully will be able to use and will be able to do more training throughout the region. So.
Can we stay on that for a second, please? So we haven't met since Spring Fling we had this last year. So our numbers were down, which we anticipated, but I think we all agreed it actually was a better for the providers they got. They felt like it wasn't so crowded. I sent letters to all the hospitals looking for some financial support. And with the exception of 1 hospital, everybody came through with funds for us to help offset costs. So that was amazing. Jonathan brought us into the 21st century. We didn't go out and buy any banners. We have it on a screen now that is revolving and showing information. And all in all, the feedback I got from those that were there was they thought it was a great conference and they liked the smaller numbers and getting together and some things that we'd added in. So we're looking at doing some new things for this year. And I think, conferences seem to be dying.
Everybody is reporting down numbers.
So hopefully we can make ours where our people in our region want to attend.
Second Harbor, I completed their inspection to their upgrade to AEMT. Some of the other stuff that we've been doing since we last met, I'm part of the state quality metrics team, the state legislative committee, and now we're going to be reviewing 0606. Attended July, and I had it on here that we're not on the agenda. July and September state EMS meetings with the next one. And we also attended the EMS memorial on September 20th, which is very well done. They did move it inside last minute, but it was nice. There was actually about 4. And there's South Chuck, Indian River, Guilfoyle, up in north. So there was 4 North Country ambulances there. Other things, I'm working with the CNY Health Emergency Preparedness, the Northern New York Child Fatality Review Team. All the vouchers were completed for REMSCO. We actually received all our funding for last year, which is spectacular. Worked with the executive committee and had the budget done, so when the contracts renewals came up, that's all done, it's all in, we're waiting state validation for those contracts for both the program agency and the REMSCO. And I'm sure the big elephant in the room is, you know, the merger, and if there's any questions on that, I'd be happy to answer them for anybody. We do have a new email, and we're gonna have a letter going out to North Country agencies that they can use that, but what happens sometimes is people email me or they'll email Jonathan, and now when there's 4 of us here, you know, or if one of us is out, we don't see that email. So the paperwork at fdrhpo.org, if you're sending paperwork in for some reason or another, like medical director updates, etc., we'll all be able to see that, and then we have a system and process to ensure that it gets taken care of. So if one of us is not here, things can get taken care of. So again, it's just a generic paperwork email as it says, so. As far as with Mountain Lakes, their REMAC and their REMSCO, you're still there covering those counties. It's only the program agency that merged, so. Our functions will be across both areas, so. And we're currently working on getting them all into the database, etc. So. Any questions for me? Been a long time. There's been a lot done, but so that's just the top of the icing on the cake of what we've been doing. Okay, no questions. Moving on to the minimum equipment requirements. So I was gonna send this out and then I didn't, just because the minimum equipment list, if you wanna pull that up, Jonathan. The only things we added to it were the TXA and the Afrin, and didn't realize that the didn't catch the protocols don't allow secondary airways for AEMTs at the pediatric level. So if you go scroll till there's yellow. There we go. So again, under optional medications, I put both of them in there. And then if you go to the airway stuff, I just removed, there should be a little yellow blotch, secondary airways from the AEMT level for pediatrics. Any questions on that?
We really have no say in that, right? That's a state thing.
That's where the protocols are right now. I did ask on the collaborative group to add them back in. And I would suggest that you do put in through our website. You can do protocol recommendations, and that I think would be spectacular if you would put that in, and I can show you that.
I can send it, the link, great.
Thank you for that.
Yeah. Because it's actually in the protocol that way. I've had it in there that way for a while, didn't notice until I went to do Sackett's question me on it. So we don't have very many AEMT level ambulances, so.
Yeah.
We have just a couple, so.
I can see that becoming a thing. There are some circumstances where that might be an issue. A couple times a year, maybe.
And the one AMT ambulance happens to have pediatric IGELs on them.
Oh, does it start with a P? The agency?
No, it starts with an L.
Oh, you might not know them all then.
But you have a paramedic on board that ambulance, so.
Okay.
It's just it's a paramedic doing the skill, 2 paramedics that are on board that ambulance, but it's only an AEMT ambulance.
Oh, it's a licensing thing.
Yeah,
Agency at one level, the providers.
correct. But anyhow,
Okay.
you're not supposed to have equipment above your level, but again, that was an honest error. So anyhow, Any other thoughts on the minimum equipment list, and if you want to table it, or if you want to approve it? Since I didn't send it out. Docs,
Approve it. Does anybody have an issue approving it?
What's your question? Why do we carry 14-inch IV catheters other than for the outdate?
the chest decompression, but I think we have those labeled separate.
It's also have to be the longer ones.
The short,
Oh, the
inch
shorter
shorter ones.
What about your 16s?
Well, that's the textbook trauma line that no one uses.
Right?
Yes.
Nobody-
That's the 16s get used.
16s get used, but I've never 14s.
I mean, I haven't sort of 14 gauge in somebody in a very, very long time, and with the new fluid recommendations, why would I?
Do you guys carry blood or are you just ATS certified?
Or just ATS?
Because that would really be the only reason to do a 14 in a trauma, like if you need to slam uncross-matched blood. But if no one's carrying it, you're right, you probably don't need to carry 14s.
I will be retired before New York State allows for grounding.
You might be dead.
So,
It's a possibility.
Yeah.
so at the trauma center, and so if they come in and you have to massively slam blood into them, what do you want EMS to have in their arm?
Whatever they can get.
Yeah.
And then we'll change it as we need to.
But if you have to do MTP, it's not like you've got an awesome vein sitting there saying throw 14 in.
That is true. Yeah, they usually get an introducer catheter.
You're usually doing something
Yeah.
much smaller.
Yeah, and then it hooks up to the rapid infuser. So I don't. Mark
Can you
brings
go
up a
up to
good
that,
point, like
Jonathan? Can you find the 14 on there, please?
maybe that's not,
IV catheter.
maybe that shouldn't be essential equipment. Because they don't get used very often. We have one nurse that uses
No,
them
not
on
that
Friday
one.
and Saturday nights on certain patients that come in.
Well, that's.
Right
Well,
there.
that would be essential
Right
equipment.
there.
Oh, yeah.
Can we get rid of them? So we aren't.
Especially if the chest starts somewhere else.
Mhm.
Yeah, that's a good point.
Can we make them optional or something?
I could just put 0 in there.
Yeah.
We don't really have optional, we have optional meds. I don't really have optional equipment. I
Just
can
take
just
it out
change it to
altogether.
0. Or take it out, because again, remember, this is a minimum equipment list.
Maya, are you good with that?
I'm good.
Yeah, Matt says he's good too.
Okay,
Thank you.
Good catch.
yeah, and that's how we pare this down.
These
It's,
things
you know,
is
is,
sophisticated.
Yeah, right.
Throw them all away, and you throw them all away. Or they get shoved in my cranium.
And you don't want them used on the mannequin either, because it makes such a big hole in the mannequin.
22 gauge, I'm a mannequin, you know, they can use them on.
anything else on there? Because I'm sure that, for cost stuff, anybody would love to have it pared down.
Mark, did you look at that whole thing in detail? As far as, because you seem to be pretty cost savvy with minimum equipment stuff. Since it affects you directly.
I mean, to pare it down much more, I don't know.
We did that.
We've pared it down
Yeah,
a
we
couple
did.
times, but,
We have, yeah.
Yeah.
okay.
We did pare it down a couple of years ago.
Yeah, because we changed it. Go up to the top, Jonathan, where I can see the header. Okay.
2 minutes. Do you have anything else that needs to be voted on?
Yep, let's do just, yeah, let's just do those couple things quick. Okay, I'm done with that. So one of the things that they suggested we do and, oh, yeah, I guess everybody good with that? Somebody
Yes.
man to make a motion to accept the minimum equipment list by Dr. Coates,
I'll second it.
seconded by Dr. Delaney. Maya, Matt, I
Yeah,
think they already
Matt
said
did,
they were
Maya
good
said
with
she
it.
was
so
good with
that- okay. All right, so I would entertain a motion, and this is for the program agency to get an ESO charting command so we can help with some of these agency failures. There isn't such a thing, but the state suggested we get a motion from our REMAC and REMSCO to push them to make one.
I make that motion.
Thank you. There was seconded to the motion Maya made to get an ESO charting command by Dr. Coates. All in favor?
add another layer of bureaucracy to, online charting?
No, this
Okay.
is so we can assist our agencies better who have ESO.
Oh, that's pretty good then.
Yes.
Okay, the problem is right now, like I have no way of getting into an ESO chart and figuring out what's wrong, where if I can get this, then
No, that makes sense.
fingers
Yeah.
crossed, I can maybe help.
Was anybody, I don't think was anybody opposed to that?
No, Matt said he supports it
Okay,
too.
and Dr. Snicers submitted a resignation letter, so I've entertained a motion to accept by Dr. Coates,
I'll second.
seconded by Dr. Delaney. Anyone opposed? Maya agreed with that?
Yeah.
Is Matt,
Matt said he agreed.
Dr. Bunch.
Yes.
And the only other thing that we had was that we had a discussion on narcotic usage. I don't know if you want to add it into that, Debbie?
We had discussed at our strategic meeting about a concern with people coming back to the hospital hours later and asking somebody to witness the destruction of the narcotics. And there's nothing in our policies that say you should do it within a certain amount of time. So we were wondering if we should be sending out something to the agencies and say, you know, there's always gonna be that exception. You went out to go do another call, but that wasn't the case with this one. And we're not really sure, so we're not sure, you know, what was going on. So we were wondering if we should have some policy that said, you know, unless there's a true exception, you have to run out to do another call, that should be destroyed at the hospital and signed and witnessed. We know when we go to Syracuse that the hospitals down there, the nurses will not do it. It's just the way it is. They won't. Do you have any problems over at Lewis County?
No, not
Over at
Wisconsin, no,
Utica?
But I've been to Syracuse and I've experienced that.
Yeah, so I mean, we have to have one of our own folks witness that, but, so we wanted to just get thoughts on that and see if, you know, do you have any issues? Do you ever see that come into play for you?
Yeah, it happens all the time. You know, it's more, it invites questions if something else happens with that case or with that provider's conduct. So it's really in their own best interest to have that documented with a tight time. So that if anything ever happens in the future, no one questions what you're doing with that excess.
So do we want the statement to say something like prior to leaving the hospital, that the destruction will be witnessed by ED staff and signed, and that exceptions will be noted why it didn't happen type deal and documented somewhere? Is that what
It's
we
gonna be
want?
difficult with ED staff depending on what's going on in the department. They may not be super enthused to break away from their other work to do it. Would it be reasonable to have somebody else on the crew, even if they're not like paramedic certified, witness it, going into the disposal bin? Because you don't have to have medicine training to see something going in the garbage.
So we did reach out to the Bureau of Narcotics and, you know, got some, you know, information back. And, you know, basically any licensed healthcare practitioner from the hospital who has CS administration in their scope of practice can witness the waste. If no one in the ER will witness, and they could try the pharmacy, but I mean, our crews aren't gonna do that, and, yeah. Anyhow, pharmacy staff are much more cognizant of the waste process and the importance thereof. The agency uses Hospital A to obtain their CSs. They could put in their agreement with Hospital A that the nurses or pharmacy staff are required or allowed to act as a witness of the destruction. Again, under other circumstances, a provider, preferably of the same level of care, can witness that. I didn't want to read all this. I was trying to. But each agency plan should have a procedure that outlines the waste process, and that's what we're noticing is lacking from agencies' plans. Potentially, so.
'Cause it could just be a sharp spin that's in the patient's records, right, at the time of report.
Ideally, you'd want to draw it up, so somebody's witnessing the
Yeah.
problem.
Yeah,
But for all they know, it's water
Yeah.
anyway.
Yeah, I know our nurses do it. We have a specific disposal area in our.
So does
emergency
Samir.
room That's, under 24-hour video surveillance. It's actually done on camera.
So, basically the staff that are witnessing, they're not attesting to what the medication is or is not. They are only witnessing the amount of liquid being destroyed. Therefore, if a medic diverted to CS and replaced it with water, they are not responsible.
Right.
So that's something to ease the concerns of the folks that are wasting it.
But it'd be the same thing, even if you brought that vial into the ED and had a nurse do it, it's the same thing.
Yeah.
Know that I didn't replace it with normal saline.
You're just witnessing the volume
Yeah,
gone, so.
Adding another layer of complexity just doesn't seem to, you're not getting anywhere.
Should we just issue some sort of best practice?
I think it's best practice and,
That
you know,
says, you should minimize the time you're carrying open.
Yeah. But you can see how it'll happen, right? Like, if it has to be somebody else that has a controlled substance license and all the nurses are busy or mean to you or, whatever else is going on, or you brought in somebody really sick, like that easily contributes to a delay,
yeah.
easily. And I know that nurses, it happens with nurses all the time, like they'll finish their shift and like, oh, I have a bottle of ketamine in my pocket. Which is also not ideal, which can open questions. It's really to protect the person that's controlling the drugs and their license and their safety, their professional safety. And I can try to smooth it over with nurses, at least at the facilities that I work at. And this expectation. Because I don't think, does anybody in North Country run dual medic rigs? I don't think so, right?
Nah, you might grab,
On accident,
just
right?
because on accident,
Okay.
two of them ran into each other on a call.
So it didn't have to be a nurse at the hospitals. Per the recommendation, I guess.
Yeah.
So, okay.
So anything else
Can you
under
bring up the meeting schedule?
new business?
Yeah, we want to just talk about the potential for the time change. So, I talked with Sarah, last week and thought that we could look at moving this from 4:30 to 5:30. If you remember way back when we had, REMAC, we typically did CQI after and it ran right into almost 7 o'clock when we do REMSCO. Well, we don't have that anymore. And so many people are dual. So, this meeting's gonna be over at 6 and we don't meet again until 7. So people have an hour to. So I had talked to Sarah about maybe changing it to 5:30. And I thought that might help people attending as well, to do that. So this is the proposed schedule for next year, February. And we know that we're supposed to have state council 4 times next year. Something about they can't go past 6 months or something to schedule them. The state doesn't allow them or something.
It's a money thing. So if they schedule 6 months out, they stay under the amount of money that requires an RFP. And then we lose all flexibility essentially. So, they are saying February, March, May, June, September, October, and then probably December.
So the one that's truly firm really is the April one for the REMSCO, because that's our annual meeting. So, once we know those, if the meeting's in March, we may look at moving the February one, but hopefully it may be before that type deal, but. So this is the proposal, and the proposal for you folks is rather than coming at 4:30, coming at 5:30.
So basically, this schedule will go to the REMSCO for approval, and we can take any of your concerns if there are any, or your acceptance of moving it to 5:30. And then it'll be finalized and we will email it out. So is there any comments on the schedule? Concerns? Okay, hearing none. Any other new business from the floor? We'll let you know when the schedule's approved. Any other new business? Hearing none, I'd entertain a motion to adjourn by Dr. Coates, seconded by Dr. Delaney. All in favor? Aye. Thank you, and I will see many of you again. back at